everybody out there. I'm so glad that you're online tonight. And everybody in the audience, thank you for being here. My name is Stuart Schlossman. I'm president and founder of MS Views and News. And we are here, and starting at an earlier hour than normal, we're here for a Compass to MS Care program. This is sponsored by Sandoz and TG Therapeutics. And exhibitors for tonight, we have Alexion, Sandoz, TG Therapeutics, and Bristol Myers Squibb. All right, Dr. Brian Steingo is with First Choice Neurology, and First Choice is one of the largest neurology groups in the country. So if you can't find him, you can find First Choice. All right, thank you. Take it away, Doc.
Hello, everyone. Welcome. And you know that I have done these kinds of programs many times with Stuart, our annual meetings. At the annual meetings that we do every year, where I introduce the land of MS, and I'm having a look at the version. This year is the 12th year that we've done the land of MS. And every year I try and put some new things into it, but you know, it's my favorite topic. So the land of MS, basically what we're saying is that the land of MS includes many topics. We're talking about MS. Any night, any time we meet, we could talk about any of these topics. For example, you've just heard talk about exercise, the importance of wellness. I'm going to talk a little bit about this tonight. What we're going to do is there's some different topics I'm going to be talking about tonight. You've been to many programs where we talk about MS medications, all the drugs that are available, the drugs, the benefits, the risks, the side effects, and things like that. Exercise. I'm going to talk to you and introduce to you some different topics tonight of interest and great importance for MS for many reasons. One reason, for example, is the aging of the MS population. Who knows what the average age of an MS patient is? Somebody like to guess? The average age. 55 is the answer. So we're dealing with a population, and let's look around, and we're dealing with a population that is aging. So what's the importance of that? Is that we start, and the importance of that we're going to be talking about is that you have to discuss what is the effect of aging on MS. What is the effect of MS on aging? What is the effect of all the medications? So those are some of the items we're going to talk about. And what about MS in different populations? So we could pick any important topic over here to talk about on any particular day. If we wanted to speak about the whole subject of MS, we could spend the whole day. We could have a symposium and spend all day about how this condition, how to manage this condition. But there are some topics that Stuart always asks me to cover, and so I'm going to cover them because he asked me to cover them. I think sometimes they're selected by audiences. So we would like, and I would like your input at the end of this, always to tell us what topic you'd like to hear more about. One of the topics that comes up is pain. So I'm going to talk to you a little bit about pain. To me, it's a very routine subject. As many of you know, many of you looking around have had MS for a long time. And there was a time they used to say, if you have pain, you don't have MS. Remember those days? You have pain, so you can't have MS. Of course, that's nonsense. We know now that pain can be very important in MS. And this is the definition of pain that they put over here, that pain is both an emotional and a sensory experience. You feel pain and you react to pain. And this shows you over here the two types of pain. There's musculoskeletal pain, which means things in the muscle and the skeleton, bone, joint, spine. And then there is nerve pain, or what we call neuropathic pain, a pain that affects the nerves. Now, when we use the word neuropathic pain or neuropathy, most people have heard of neuropathy. And the commonest cause of neuropathy in the whole world is diabetic neuropathy. And that is what we call a peripheral neuropathy. What happens is the nerves themselves that run in the legs and the arms, they're involved in diabetic neuropathy. That is a peripheral neuropathy. In MS, the neuropathy is different because it involves the spinal cord or the brain. That is the central nervous system. So it's a different kind of involvement. It's not the nerves on the outside, it's the brain and the spinal cord that could be involved. At the bottom there tells you about some types of pain you might have. You might have an acute pain that just suddenly starts. You've never had it? It suddenly starts. Well, it's chronic. It's been there for weeks or months, or it's paroxysmal. It comes and it goes. And we'll talk briefly as we go along about some of these types of pains. So here's musculoskeletal pain. Common. People have muscle stiffness and spasticity and muscle spasms. And we're going to talk about the next topic briefly about spasticity. Very common and often disabling in MS. There are people that have no weakness, but they cannot walk because their muscles are so stiff. And then you have what we call secondary pain. secondary. It's because it's not directly from MS. Headaches may come from MS, but most headaches that people get from MS are because of other conditions, other pains and spasticity, or back pain. So most back pain that people get from MS, they could have spasms in their back, or because of the way that they walk. Unfortunately, they don't walk normally, so their gait is abnormal, and that put abnormal stress and strain on the back or the hips or the knees or the ankles, and so there's joint pains and aches and pains as a secondary pain because of what the MS has done. Let's look at a neuropathic pain. It says it's often in the limbs, it's in the hands and the feet, but it can be anywhere. It can be in the face. It can be in the tongue or the scalp. Neuropathic pain can be anywhere. So any kind of feeling that you have can be a neuropathic pain. Here's some listed: burning, stinging, electrical, tingling, cold, itching. And it can vary. It can be intermittent or constant. It can come and it can go. The skin could be sensitive to touch. And often neuropathic pain is worst at night. Here is a specific kind of pain listed as trigeminal neuralgia. It covered some of the descriptions we said earlier. It can be acute, a sudden onset of a severe facial pain. It's paroxysmal. It comes and it goes. Usually brief. It doesn't last for very long. It would be bad news if it lasted for long. So it comes and it goes, but it could be incapacitating to the point where somebody can't even swallow sometimes. So that's an example of an acute pain that can be chronic. Means it will come and it will go intermittently for a long time. And then there could be other neuralgias, other types of pains, like a trigeminal neuralgia. Somebody can get shooting pains that come and go in other parts of their body. An MS hug is an example of a neuropathic pain that can come and go. So there are many types of neuropathic pains for us to deal with. This over here, right at the bottom, you'll see where it says the old CART acronym. That comes from the MS Association of America. They published this and they said, when we ask you a question about pain, these are some questions we ask you. How did the pain begin? The onset. Where is it? How long does it last for? What is the character? Sharp, dull, lancinating. What aggravates it? What makes the pain better or worse? For example, if you bend your head down, you might feel tingling. Common in MS. It's called a Lemaitre sign. I'm sure half the people with MS in here have had that. What makes the pain worse? What makes it better? And then how do we treat it? Treatment of pain. So you'll see over here, there's basically two groups of medications that we mostly use to treat pain. The first group is the anti-seizure medications. Anti-seizure medications, you know these gabapentin and Lyrica work on a similar pathway. It's the commonest medications we use for neuropathic pain. Carbamazepine. There's Tegretol and oxcarbazepine. Those two are related. Those for all seizure medications, they all work very well. They have potential side effects. For example, carbamazepine has side effects, which are important in MS patients. It can cause loss of balance. So that's an important side effect in an MS patient. It's very effective, more effective probably than gabapentin, but more side effects. So that's the anti-seizure group. The second group is the antidepressant group of medications, like amitriptyline. Amitriptyline is old. It's an old medication. It's been around for a long time. And then we have newer drugs like Cymbalta, all in the group of antidepressants. And finally, at the bottom, sometimes used for MS pain, cannabinoids. Cannabis, THC, CBD, they do help pain, they do help spasticity, but they have side effects. They have two groups of side effects that are important. One particular side effect in people with MS is loss of memory. There are studies that have been done that show that people that take regular use of cannabinoids have loss of memory. And you've got MS, you've already got some risk for a loss of memory. And becoming more important, older patients that have other conditions that may cause loss of memory. So cannabinoids need to be used very carefully, especially in our older patients. That's the one side effect. The second side effect, cannabinoids, that becomes more important, especially in our older group of patients, is effects on the heart. Cannabinoids can increase the risk for arrhythmias, like atrial fibrillation. So these medications must be used carefully. It's not fine to just go and say, let's have some pot. Also, the medications that work best are the non-smoking forms of cannabinoids, not the smoke type. Just pills and creams and lotions and things like that might help more with the type of pain of MS, not the smoking type. The smoking type might be good to make us happy, but that's about it. Musculoskeletal pain. How do we treat musculoskeletal pain? So we can use, you've just heard about that with Jeff. So we exercise, stretching, massage, things like that. Exercise, very important for musculoskeletal pain. Using medications, non-steroidal anti-inflammatories in limited amounts. We don't want to get anybody dependent on those because those too have side effects. Chronic use of non-steroidal drugs can affect various other organs in the body, can increase the risk for heart disease, kidney disease. So we must use those carefully too. And then the antidepressants, same as in the previous slide, the antidepressants. They may help this pain too. And then antispasticity drugs like baclofen and tizanidine. We also use Botox, which basically paralyzes muscles. That's the way it works. Cannabinoids again. The last resort is opioids. So we hardly ever use opioids for MS pain. We try and use all the other measures first, but there are situations where people have pain that is ongoing, life-changing, and none of our measures work, and we sometimes will have to refer them for pain management to control their pain. The second topic that Stuart has asked me to address, these are symptoms. When we looked at the MS tower, that's why it's called the symptom tower. Remember, in the land of MS, we have a symptom tower because there are so many symptoms. So all this stuff that you're seeing over here, sometimes you have an option. I can put a slide and put 2 points on a slide. I sometimes like to leave it a little bit cluttered like this because you can always refer to it later. Remember, all the stuff that we're doing today, thanks to the team on the table, this stuff is going to go, eventually is going to be online for you to be able to look at. Is that right? It's going to be online, archive, when? How long? About a month? 1 week. So all this will be there. So this is introductory, so you can look at it in more time. But this tells you what spasticity is. It's stiffness. It's the stiffness in the muscle, and it can interfere with the movement. So someone could have good strength, but their legs are so stiff that it becomes very hard to walk. And spasticity can be triggered off by many things, including commonly infections. So infections will commonly trigger spasticity. Upper respiratory infections, urinary tract infections, and stress, and any other condition that goes on, all of these can stimulate spasticity. Now, spasticity causes tightness of muscles, and if the tightness is not released, or we don't stretch, and we don't treat it properly, eventually the muscles will become tighter and tighter, stay in that position, and it might cause what we call a contracture, when it becomes more and more difficult for that limb to extend. And it can happen in the hands, and it can happen in the legs as well. And it is very, and people with MS have fatigue to begin with. So now you add the laborious effort to walk when there's spasticity increases and causes a lot more fatigue. And here's some treatment. There's overlap over here, as you see, with pain and spasticity. There's a lot of overlap about how we manage it. The difference is with spasticity, the importance of exercise. You've heard from Jeff, the great importance of exercise in general with MS, but stretching, physical therapy, occupational therapy, very important. And the most important thing about the physical and occupational therapist is to be an educator. So what you need to do is you see them. I've seen people see me and they'll come back and see me 3 months after the visit and say, I saw the physical therapist, it was a waste of time. And I say, why? They say, I didn't get any better. I say, that's not their purpose. Their purpose is to teach you, because getting better takes a long time. It must become part of a lifestyle, part of a habit. So they teach you what things to do. The medications, there's medications for spasticity, the cannabis again, Botox. Sometimes if baclofen doesn't work and we need a large dose, we do what's called intrathecal baclofen, where a catheter is inserted into the spinal canal and the baclofen is pumped in via pump directly into the spinal canal. The last resort right at the bottom of this slide is surgery, and that is used when people develop contractures. If somebody has severe contractures, especially in their lower limbs, and their limbs are tightly crossed, for example, and you can't separate them, then sometimes surgery is done to cut tendons. That would be drastic, but necessary sometimes. The point of this slide, another busy slide, and there's another one that's on the archive, and it's another one worth looking at, is that when we're treating you with MS, it's not simply saying, well, let's give you your medication and have a good day. There are many medications because there are many symptoms. Look at this list of medications that you could be taking for fatigue or depression or spasticity or pain or your bladder or bowel or cognitive or tremor or walking medication. We have a ton of medications. Now add to this that you could be taking other medications for other conditions, and we result in polypharmacy, which means using many medications for your MS, the MS drugs, for your MS symptoms, for other conditions. And so sooner or later you're taking a lot of drugs, and so we always need to be wary of this and prepared for interactions. It's a very important topic every time. The good news is that many pharmacists, so firstly, if I prescribe a drug, I have on my phone an interaction checker that I could use. Secondly, when you get a drug from the pharmacy, in general, they should also be looking at the interaction checker, and you yourself can check for interactions. And so this is because people have many diseases, especially in our older population we're speaking about, and these drugs can interact. A drug formulary can change over time. They make us change our drugs. Sometimes they don't even warn us. All of a sudden they change the drugs. People use more and more medications. Doses can vary. In older people, the dose might be different from a younger person. And then there could be poor follow-up or poor monitoring. People not taking the dose as prescribed. So polypharmacy, management of the drugs is very important. So when we spoke about the topics of pain and spasticity, that's only two topics of the many symptoms, and we always have to be aware of what we're prescribing. Now, one item along the way, Stuart had given me some different topics to talk about, was newer drugs for MS, and I'm not going to go into any detail on this. I'm simply listing for you over here some of the drugs for MS. For some of you remember, and I'm sure some of you were, remember that our first approved drug for MS was beta-seron in 1993. It's amazing, actually, to think about that. Beta-seron this year is 31 years old. 31 years old. And since then, we have many drugs approved, with the generics and all the other drugs, over 20. And some of the drugs that we have originally are not even there anymore. There was a drug called Eclusumab, but we don't even, it's off the market, taken off the market. There was a drug called Novantrone 20 years ago. It was a powerful drug, chemotherapy drug. Side effects were catastrophic. Nobody uses that anymore. So we have had many drugs along the way. They work differently. It's very important for us always when we put someone on a drug to pick the right drug for the person. It could be based on many things. It could be based on what kind of MS they have, what's their age, what's their gender, what other conditions do they have. It could be based on many things. The most recent drug, the most recent drugs approved, both have similar mechanisms of action. They work on B cells. So drugs that in MS with a dysfunction of the immune system, many of our drugs work on parts of the white blood cells called T cells and B cells. Recently approved drugs work on the B cells, and they lower or deplete the B cells. So this is our mechanism of action. There are potentially new drugs coming along. Some of the new drugs have stumbled along the way. So we're hopeful that drugs will be approved, but I wanted to put this slide up to show you about what's some of the topics that we're looking at in research. On the left-hand side, on your left-hand side, neuroprotection and repair. How do we protect the nervous system from further damage? And very importantly, is there anything we can do to repair the nervous system? So we're trying to learn some techniques to repair that. Every now and then you'll read about drugs, sometimes drugs used for other conditions that might have some effect, for example, on myelin. And so stem cell work has been going on. Stem cells definitely beneficial in the right patients. The stem cells work on repairing the immune system. The stem cells are not stem cells that repair the nervous system. We do not have any stem cell study where the stem cells repair the nervous system. They repair the immune system. They reboot the immune system so the immune system stops attacking your nervous system and your MS can stabilize and maybe recover because it's not being attacked. So that is what stem cells are meant to do. In this country, they're not approved for MS. There are places outside of the US where they do them regularly. In the US, it's mostly done on a trial basis. Someone would have to get into a trial. But stem cells are definitely beneficial for selected patients. At the bottom left is the very important topic of aging and the immune system. And aging and MS, a lot of work being done on that. I'm going to spend a bit of time talking about that. The next point over here is efficacy and safety, trying to improve the safety of our drugs. We have had along the way some very effective drugs. For example, alemtuzumab or Lemtrada, very effective medication, but side effects make it very, very rare that we use it because of the side effects. So we're trying to find always new drugs with less side effects. We want to improve symptom management. We have a medication, for example, for walking that is only 10 years old, but there are some symptoms of MS that we don't have good medications for. Tremors. The tremors of MS can be very incapacitating, and we do not have any good, reliable medication for tremors. Finally, on the right-hand side, the important topic of the diet and the microbiome, trying to make people eat healthy, have the right type of diet, the effect of the microbiome, which is all the bacteria that live in our body. There's a lot of work going on about that. That in itself is a full topic. So there's a lot of work going on about that. And then at the bottom, the little rectangle at the bottom says biomarkers. We're working on that with MS. A biomarker is a biological marker that you have MS. We don't have a test that actually says you have MS. If you have rheumatoid arthritis, we can do a blood test that says you have rheumatoid arthritis. If you have Graves' disease, we have blood tests that say you have Graves' disease, other diseases. If you have lupus, we have a blood test. It says you have lupus. We don't have a test like that for MS. Even your spinal fluid, we can do spinal fluid. We put all the information together and say, this suggests you have MS, and then we have to rule out other things. So we're looking for the actual marker for MS. What we do have now is the biomarkers. At the symposium, at the MS Views and News Symposium last November, I did speak about to the biomarkers, so that's online, archived. There is a company now that has a test that you could have your blood drawn, and we could look at biomarkers, and what they're meant to tell us about is MS disease activity. So they do not allow us to make the diagnosis still. There are tests that say how active is the MS, and we might be able to use this potentially to monitor your MS. So we could do a biomarker level, and you go on treatment, and then maybe 6 months later we check the level again. These are things we're still learning about. This is still evolving. So some of the stuff in research. Treatment challenges, an important topic. Again, a topic that could go on a long time. So what treatment topics, challenges do we see? Issues with cost and insurance coverage. This is a constant battle that I have, and my medical assistant particularly. There's not a day in which we're not fighting with some insurance company about something, that some drug or something is not approved for one reason or another. Even if someone's been on a drug that they're saying it's not on the formulary or it's third tier or something like that. And then the cost of it. It's become more difficult to get financial assistance. So we have to figure out ways of getting costs to help people. And then there may be a lack of trial data in certain groups. For example, many of the clinical trials in MS are done cut off at age 55. I just told you the MS population average age is 55. What about a 58-year-old MS patient? If you go by their study, they say, what would happen in a 58-year-old? So a lot of trials cut off at 55. We don't have data. And then also look at the nature of the trial. You look at a trial and say 92% of people in this trial were Caucasian. What about our other populations? African American or other populations? What's the effect of the drug? We need to have more diverse trials to understand the effect on all people with MS. Patient health literacy. Do the patients understand the modern trend with medicine? You know what it is. You go into the office, how long do you get to spend with your doctor? Are you in and you out often? You tell me. So people may not get a lot of time to have things explained to them. And sometimes they'll go and research, but sometimes they can't. Some people can't. I see patients even now, some especially more older patients, they're not computer literate. It's hard for them. If you don't give them the information, explain to them, they're never going to find it. And patient communication. The communication can be much better. Many offices have a portal. We have a portal. Many other offices have a portal. You can write a message to your neurologist and you can say a question. So that's what the portal is meant to do. It's meant to be questions and answers. It saves you time. It's easy to write in a portal and send a message and say they never got my message. It's easier to get in a portal. Again, many people can't work with portals. But patient communication is very important with the portal. And then the availability of people. Where do they live? Are there any clinics nearby? Where do they live? I constantly see people. I saw a patient today, for example, who's 64 years old and diagnosed about 30 years ago, took Avonex for 7 years, and nothing since. And she came to see me with a walker. She's just been in the hospital for a relapse. Quote, I don't know if it was a relapse, but no, totally unaware of treatment. And I said to her, so I'm going through, I said, who have you seen in the past? I said, have you ever seen an MS specialist? She said, I never knew they existed. I said, there's 20 drugs. You have to see somebody who knows how to manage this. So it's very important to have access to the appropriate people. Social determinants of health is a big topic now. It's even got an abbreviation. It's called SDOH. And there are many, if you look up this on the internet, social determinants of health, you'll see that there are many factors that are involved in determining someone's health condition. So there are individual factors, gender, race, ethnicity, and sexuality, that determine someone's response and their access to health. Family, friends, and community. It helps. If someone has more support from family and friends and community, the outcomes are better. There is no doubt about that, that people that have better support do better. So very important. Education, someone's education, their skills, their work, all these things are further social determinants of health. Personal resources, money, food, and housing, the neighborhood where you live, transportation. These things are very important. Someone finding transportation, they can't get there. They can't drive anymore. There's nobody to bring them. There's all kinds of problems for that. And then in that situation, oftentimes you'll find someone like that that's got some of these difficulties with transportation, and now you say, well, maybe we can help you out with some telemedicine that I'm going to discuss in a minute, but they don't have telemedicine access. They don't have appropriate telecommunication tools. So a lot of difficulties, and we have to be aware of these people, because these people drop between the cracks, and we have to be aware of them out there. Interpersonal violence. Do you think interpersonal violence in MS is high or low? It's high. It's not only interpersonal violence, it's violent. People with MS, unfortunately, have a high risk of violence. And it's perpetrated most commonly by the one that is most the candidate for the best help, and that is the spouse, or the significant other, or the person in the home. So domestic violence against MS people is common. I've been fooled many times in my practice where the caregiver will accompany the person with MS and seemingly is the most caring person, but is actually an abuser. So home violence, we have to be on the lookout for that and find a way to find out about that. Violence outside of the home. Think about that. You know, in our society, all day, every day, you turn on the news and somebody got beaten up or robbed or something. Well, here, you're out there in the public and you're walking with a walker or a cane, and some bad dude might just say, well, it's an opportunity. So violence, so awareness and violence, very important things for us to be aware of all the time. Prime organization published this over here. This was their data findings. They talked about long-term outcomes and life expectancy with MS, talking about the things that could shorten life expectancy. And one of the things that has improved is the effect of MS itself, that we have much better treatments for MS, but there are other factors that are involved with MS. Some of them we're going to talk about with aging, but the risk of falling, the risk of infections, the risk of other diseases, and then mental health and emotional wellness can be affected with MS. We need to be aware of that. Depression, the risk of suicide with MS, unfortunately being very high, higher than any other chronic disease. The risk of suicide in MS higher than Lou Gehrig's disease. Could you imagine that? Lou Gehrig's disease almost in most people a death sentence. Most people don't survive beyond 5 years with Lou Gehrig's disease. And yet the suicide rate in MS is higher than Lou Gehrig's disease. Lifestyle and health recommendations, the importance of exercise, diet, goals for treatment, different treatment options, satisfaction with treatment, and the need for regular follow-up care and monitoring. So these are all things, these are questions. So what is it that a patient should ask their doctor? And what this is showing you over here is the things that you need to speak to when you're diagnosed with MS or when you have MS. These are all topics you could ask your doctor about. Are you satisfied with your treatment? When should I follow up? Any advice to improve my life, etc. All of these things that you see listed here was a list of things that people said they did not have enough time to speak to their doctors about. And how do you improve that? Is that when you go for your visit, you should always have a list of questions. Not here. That's not the place to store it. It's good if you can store it there. It should be there, but it should be on other places, on your tablet, on your phone, on a piece of paper. There should be a list of questions. So when you leave, 5 minutes later, you don't remember, oh my goodness, I forgot to ask about my bladder. That's not a 2-minute question. The bladder is not a 2-minute question. Not at all. So very important to make notes and write down your questions. Always keep a list of your questions. And we'll talk briefly following that about telehealth in medicine, which is using technology, telecommunication, digital And there are two types, as you see. There is synchronous, which is obvious, where we're speaking together on the phone or video. And again, some people have no video capabilities. We can try and speak to them on the phone. It's limited. There's only so much you can do. Of course, there are limitations of this. And then asynchronous, which is all the other modern telecommunications that we have, such as the example that I gave you of speaking on a portal, making notes on a portal, writing to your neurologist and saying, can I get a refill? Or something on the portal. A portal is a brief message. It's not meant for more than that. I can tell you, I have some patients who think that I'm their pen pal. It's not the idea. I don't want to be a pen pal. So there are people who constantly writing to me messages. Actually, the interesting thing about that is that most of them are healthcare professionals. So they're writing messages to me, and you can get brief replies on that. So when they've studied this, there have been multiple studies done, and it's shown that most people are quite satisfied with telemedicine and telecommunication. But it lists for you at the bottom that with some symptoms, this is an advantage. If somebody has difficulty with transportation, bowel dysfunction, bladder dysfunction, they can't get out easily, fatigue, many different problems, these are people where it might be easy for them to do some telemedicine. Clearly, ideally, somebody could have one tele visit intermingled with the live office visits. So the benefits are limited, are listed on top there. You don't have to travel. So people have transportation difficulty. Travel's costly for them. You can eliminate that. They don't have to take time off work, maybe, if we can make the right schedule. And particularly their partners who support them might not have to take time off work. They might not need to arrange childcare. It improves access. You can have care that you might not have been able to get. You can at least speak sometime to a specialist that you might not have been able to access. And then you can also be in your own home. And here's some disadvantages. We can't do a neurological exam. That sometimes is important for us to do. That's why you need some live visits interspersed. And then the bottom one, the widening of healthcare disparities, which we've been belaboring for a little bit here, is some people don't have access to these tools for telecommunication for various reasons. And you'll see some people that are on some disabled groups, people receiving Medicaid, people that live in rural communities. So people with lower socioeconomic conditions, older age, may be harder for them to communicate and harder for them to get some of these tools. And so we need to be aware of all these things. And here are some resources for MS patients. Stuart would like me to say in order of importance, but here are some resources that you know about. There are resources and we should use them. MS is a very expensive disease, and there are two types of costs for MS. There's the direct costs and the indirect costs. Direct costs, for example, are the costs of your medical services, your medications, rehabilitation, etc. 75% of the costs for MS are the direct costs, and 25% are indirect costs. For example, transportation, people taking you for transportation, changes in your employment, etc. So 75% of costs for MS are the direct costs of the health care. What do you think the cost of MS is to the US economy in 2019? Anybody want to guess that? I'll give you a clue. I'll start you off with billions. How many billions? The answer is 85 billion. The cost of MS to the US health is $85 billion, of which most of it is direct costs. Why am I showing you this slide? One of my favorite slides is of the different kinds of MS that you see. We have different stages of MS, but from the relapsing MS, we move on to the next stage of MS. After relapsing, some people start to slowly progress, and we call that secondary progressive. And we're now starting to look at secondary progressive in different lights. We look at secondary progressive where people are not active. That was typical secondary progressive, that somebody was progressing without relapses. But we have a category now of active secondary progressive, where somebody is progressing slowly but still having a relapse. They're going between one stage and the other, and where the MS is smoldering. So we're thinking that there are people that have smoldering MS. So people that continue to get worse despite ongoing inflammatory activity. How do we know there's inflammation in your brain? Now, we know there's inflammation when we do a scan. When you do a brain scan and it lights up and you see active lesions, we know it's inflamed. There's an inflamed area. Typical relapsing MS means there's inflammation in the brain. So we know that people are not inflamed. We do scans, the scan doesn't show any inflammation that we know of, yet they're getting worse. Their scans they're getting worse, but their scans are not worse. How often have you known that? Everyone has known that you come and see a neurologist and my walking is worse. My cognitive stuff is worse. And we do a scan, it looks the same. Hasn't changed. And why? Because there can be progression that is independent of relapses. So we can see worsening that is due to a relapse, but we can also see progression independent of a relapse. And these are new words that you're going to hear more and more when you come to more and more programs like this. Progression independent of relapses. And the MS, the term we're using now, is smoldering. The MS is smoldering. There's something going on in a low grade that we're having difficulty measuring, but there is something happening in the brain, and we are not shutting it down. All the medications that we have maybe are slowing the progression, but they're not shutting it down. And it's because there's some smoldering activity that's going on. Smoldering MS, progression independent of relapse. What this slide is showing you over here is risk factors and prognosis in MS. Why I put this up again, that I love to put up every time, is you'll see there are various factors. Number one factor on top there, though, is age at onset. So if someone has MS at 20 versus someone who has MS at 50, what are the outcomes? Now, the person who's 20, by the time they're 50, they've had MS for 30 years. But the person that's 50, the MS is worse. MS is worse when it starts in an older age. That's essentially what the importance of this is, that MS is worse. There are many other risk factors. Where is the MS located? How much recovery is there? How many attacks does someone have? But what I wanted to point out to you there is the age. And I'm going to talk, the last section here I'm going to talk about is aging and MS. And this is firstly the type of MS. So in relapsing remitting MS, typical patient, 20 to 40 or 45 years old, more common in females, 3 to 1. Typical relapsing remitting MS that we know about. How about the other type of MS? Progressive, primary progressive MS. Older patient, 50. Males and females, equal, 1 to 1. Slightly different. What's the difference? Are they different diseases? Or is it just a different, is it all one spectrum in a different way that the disease is showing? In other words, when someone has relapsing MS, we know there is a lot of inflammation in the brain. When they have progressive MS, there's less inflammation and there's a degeneration of brain tissues going on. But both types of MS have both things happening, inflammation and degeneration. All our medications now are very good to shut down inflammation. They're not as good for degeneration. And this is what we're out there looking for in all our research, to find medications that can slow down the degenerative component of MS. Aging in the MS patient. So, older age was associated with a higher disease of getting more disabled. So if an older patient starts, they may reach disability status more quickly. Doesn't matter how long they had the disease. So onset at age 40 or age 50 doubled or tripled the risk of developing secondary progressive MS compared to age 20. So older patients more likely to reach a disability status than a younger patient. What about comorbidities in people with MS? Very important. We're talking about older group of patients. What other conditions do they have? And what do these conditions result in? They result in a delay in the diagnosis. For example, someone has, the commonest one is progressive MS. Progressive MS often affects people's walking. They have trouble walking. Their walking slows down. They start to limp and drag a leg. So what's the first thing? How many patients do I see that they'll come and say, well, they told me it was my back. I have a pinched nerve. How long have you had it? 5 years, my nerve's been pinched. And it's not. It's something else. So we have to hopefully find physicians that people see, orthopedists or anybody else, that are saying there's something not right here. This doesn't look like it's just a pinched nerve. So someone who's 55 or 60 years old is going to have bad back. You do an MRI, you're going to see arthritis and pinched nerves and degenerating discs in their back. But there could be other things going on that we have to think about that can delay the diagnosis. Or somebody will blame it on something else. Well, it's because you're old, or it's hardening of the arteries, or it's something else. And so with the other diseases that are going on, the diagnosis can be missed. And I've written over here some of the other things that we can see with MS. The first one is cardiovascular or metabolic disorders. It's a very important section. It says MS has been associated with a higher risk of cardiovascular disease. We have no idea. We do not understand why. It might be a genetic thing. But people with MS are at higher risk from having cardiac problems, cardiovascular problems. strokes. We don't know why. So it's very important to pay attention to this. And so, for example, many of you know, you've heard me speak about diet. I've always believed diet is important, but it becomes even more important when we say we also have to manage the cardiovascular risks of having a healthy diet, making sure the cholesterol is at good levels, making sure diabetes and hypertension are controlled. So it's very important to control these factors associated with age. And then musculoskeletal problems, that's what I used as the example. Someone having a back problem, for example. Psychiatric problems, depression, anxiety, bipolar disorder are common in people with MS. Other neurologic problems, memory loss, dizziness, gait dysfunction. There are many causes of memory loss. And in an older population, if we take someone, say we look at an 80-year-old person, 80-year-old people, and we say that, let's give a round number, 20% of people at the age of 80 have Alzheimer's disease. Well, how many MS patients at that age have Alzheimer's? The same amount. So if we see somebody who's 70 years old with a memory loss, and we're thinking, well, this is just my MS that's causing my memory loss, let's see, could it be something else? Could it be Alzheimer's? Yeah, it could be. Is there any point in working, studying that, doing testing? It's becoming more important as drugs come, as we start to get drugs approved for Alzheimer's disease, it could become more important to look for other causes of memory loss as well. And dizziness has many causes besides MS, inner ear problems, heart problems, medications, many other things, and gait dysfunction, difficulty walking, many other things that can contribute to that. Sleep disorders are common as people age. It's well known as people age that they sleep less. They have trouble falling asleep. They wake up, they sleep less hours. And MS can also cause sleep disturbances, so we also have to constantly evaluate that. And how about the bladder? Bladder problems with aging added to MS problems, gastrointestinal problems, and then cancer and MS. And this is kind of conflicting. It's really, there was a time when people said if you had MS, you had less risk of cancer. But really, there probably is nothing different from the general population. And then we have to think about, so everything we've spoken about is the MS person and aging. How about the drugs that you take for MS? Because we're dealing with this condition called immunosenescence. You've heard of the word adolescence? Adolescence. Now we have a word immunosenescence, which is mean the aging of the immune system. And when the immune system is aging, it can't respond in the same way. The responses to drugs are different. So it's something very important to think about. If you're giving a person a medication, what's the effect of the medication in someone who's an older person? So that is the end of the slides. So we can go ahead and take any questions.
Does anybody have a question? First, let's give him a round of applause.
So something I ask every time we have a program, I suffer from a lot of pain all over constantly. I'm on every medication that you mentioned, from antidepressants, seizure meds, cannabis, everything, opiates. The doctor wanted me to try gabapentin, and it made me very anxious, so I stopped. Is there anything else that in that class that I can try?
There's everything I put on the screen. There's nothing else. Gabapentin is the first-line medication, but people, and the range is amazing. Some people will take 100 milligrams and tell you that they're sleepy, and some people can take 5,000 milligrams a day, and it's like they're taking nothing. So it's a huge range of tolerability of gabapentin. Lyrica is similar to gabapentin. They work in the same family, so using one or the other doesn't make a lot of difference. Then we have carbamazepine.
I wrote that down, yeah.
It's a very good drug. Tegretol, very good medication, but it's got side effects, especially in people with MS. If they might have trouble walking, it can cause loss of balance. It can affect the blood count, the liver. It needs to be monitored very carefully, carbamazepine. So that's all that there is in that group. The antidepressants you know about, you've tried them, you said.
I have RSD in my arm, so when I get pain bouts, they're like, 15 pain levels. So they're totally debilitating. Yeah. And I've tried like everything.
Yeah, there's nothing other than these things. There's sometimes if you have something other than MS, than a sympathetic nerve block, if you have did you say you have RSD? Yeah, sometimes have you visited pain management doctors?
Oh yeah, I see somebody.
And did they ever talk about sympathetic blocks?
I've had blocks, I've had the steroids, I've had the injections. I can't get relief.
Yeah. No.
And then it's
this-
depressing and it's, frustrating because I just live like on a 4 to 5 all the time,
Yeah.
so.
Now, other than those things, or if you've got another condition like RSD, to do a block, there's nothing else, unfortunately.
All right, thanks.
Are you taking new patients?
Are you taking new patients?
I do see new patients.
That's her question. What days of the week are you there?
Monday, Tuesday, Wednesday.
Thank you. How long to wait is the wait to get in to see you?
Not very long.
Okay, we have a question over
Plus,
here.
I also have an associate now. I have an associate who is MS trained. She's fantastic. She trained in Buffalo at the Buffalo Neuroscience Center. Between the two of us, we're certainly able to see new patients.
Dr. Steingo, I'm looking at an article that came out recently that says scientists crack mystery of how MS genes spread.
Firstly, there are some diseases that are genetic. What that means is that there's one gene responsible for the disease. So if somebody in the family has it, subsequent generations are at high risk. For example, hemophilia is an example of that, or sickle, some inherited diseases. With MS, there isn't one gene that's responsible. So there's many genes that may be, a whole pattern of genes that may be dysfunctional. The study you're referring to probably is the study where they looked back at ancient people and they said, we're looking at MS and we're saying maybe the genes that cause MS are also the genes that protect you against some other things, which is why we're seeing an increase in MS. So I think they're just looking at some patterns and making a theory. I think this is it was an interesting study, but it's not proved. It's just I did see that study. It was very interesting, talking about why you get MS and maybe why protect people against some other diseases. So, but it's complicated with MS because there isn't one gene that you can pinpoint. This is the gene that causes MS. There's no such thing. There are multiple different genes involved.
Thank you. So there's a person online that just asked if Tysabri is going generic.
I mean, I can't tell you what the FDA approves or not, but yes, there is a generic form of Tysabri. I can't tell you if it's approved or not, but there is certainly a generic form of Tysabri in the works.
Could they be speaking about the biosimilar?
Yes.
Can you answer anything about that?
Yeah, I mean, it's not. It's as far as I know, it's not approved yet. So I can't say more to it because it's not approved. But it could be that it's possibly a biosimilar agent, which means it's an agent that is biologically similar and has been shown in trials to have the same effectiveness as the other biological agent. Tysabri is a biological agent. It's not just a chemical compound. A biological agent means that it's produced from biological substrates, not just from a chemical substance. And therefore, when you make a biosimilar, it's also used from biological agents.
Thank you. Another person is asking, what do you do about burning hands and feet?
Yeah, so burning hands and feet is part of what we talked about, neuropathic pain, burning, tingling, electrical, all those pains, the same list of medications that I showed that are used for neuropathic pain, all the same anti-seizure medications, antidepressant medications, that same list of medications.
Okay, and another one, I don't know if you can answer this, but they're in rural America and they want to know what they can do. They can't drive, they don't have family around, there's no buses where they are, trains or whatever, and they need to get in to see an MS neurologist, new, and they can't do it online. So what would they be able to do? Who can they call? Ghostbusters.
So I did put a list of MS support groups. That's the starting point for everybody, is to call the support groups. MS Views and News is an educational organization. Sometimes the MS Foundation is involved with helping people get transportation through Uber or Lyft, predominantly through Lyft. So they might be able to find some local service like Uber or Lyft to give somebody assistance. They might call the MS Association and the MS Society, who might give them a grant to be able to find somebody, either Uber or a cab or somebody to give them a ride. But I think anybody who has that situation, it's good that they're asking the question, because they need to call one of these organizations and ask them who can give them assistance.
Okay. Last question online is asking about cognitive testing. What can you tell them is what's the baseline, how often they should get it, and I got to sit. I can't see it anymore. And yeah, is there a way that it could be done at their doctor's office, or must they see a neuropsychologist?
Yeah, I mean, ideally, they must see a neuropsychologist. In the doctor's office, we can do testing. It's brief testing. We're going to do a test that's going to take 20 minutes. I mean, it's time consuming. So we have many other important topics to talk about in the visit. So we're generally going to send somebody to the specialist, which is the neuropsychologist. The main purpose for neuropsychological testing, there are several purposes for it. So again, that will stratify the age of the patient. If we're doing neuropsychological testing in our older patients, we're looking to see if there could be other diseases. It so happens in the past month, I've had 3 patients that have tested. There's now some blood work that is suggestive also for Alzheimer's disease. I've had 3 patients that tested positive for the blood test, all had family histories. Last patient had a mother and grandmother that had Alzheimer's, and the testing came back positive. And so neuropsychological testing is important in that situation to say to us, what's the pattern? Is this a pattern of MS? Does this look like MS's pattern, or could this pattern be some other thing like Alzheimer's, or is it hardening of the arteries or some other condition? So that's one group where cognitive testing is important. And then the other big group, really big group, is for younger patients who are working and are struggling at work and applying for disability, but physically look good. When you look at them physically, they're not bad, but cognitively they're not good and they can't work. And the insurance companies will look at them and say, "Oh, you look fine. You went to see our doctor who happens to be an internist or something. He said you look fine. You can work." That's where neuropsychological testing is also very important. So it's mostly important in those groups.
Okay. Last question online now is Briumvi versus Ocrevus. Is it worth changing to save the time?
In terms of time, is a person's own decision. So if someone is on a drug, there are certain reasons for taking someone off a drug. The most obvious reason for taking someone off a drug is it's not working. If the drug's not working, you want to switch the drug. Second reason for someone coming off a drug is it's not safe. The drug has side effects. So that's the second reason. The third reason that we hate the most is insurance. The insurance might say, well, they can't get this drug anymore. They force us to change the drug. So those are reasons why we change drugs. So the answer to that question is depends on the reason why.
Thank you.
If it's just a time reason, that's the person's decision.
I'm just curious, what do you think of the drug Mayzent?
Mayzent is an effective drug. Mayzent is a drug that was studied originally when the study started. Actually, one of the groups for Mayzent was secondary progressive MS. And in fact, it did show some benefit for secondary progressive MS. But Mayzent is in a group of drugs we call S1P drugs. It's other drugs in that group, for example. Gilenya is in that group. Zeposia is in that group. They're called S1P drugs. I use those drugs. I predominantly use those drugs in younger patients. There are some people that think that Mayzent, because of the trial, might work better for secondary progressive MS patients, but it was not approved by the FDA, particularly for typical secondary progressive. It is approved for active secondary progressive. But then so are all the other drugs in that group. So such as Zeposia or Gilenya is the oldest one. But I think the newer drugs in that family, Zeposia and Mayzent, I think have a lot of advantages over Mayzent. So I think it's okay. It's okay if someone is using that drug. I don't object to it.
Works on the lymphocytes in general, not specifically a B or T cell drug.
Okay. Anybody else? Oh, now you do.
No, it works on lymphocytes in general, not just B. It's not specifically a B or T cell drug.
Dr. Steingo, you've talked in the past about studies where they're trying to determine if older patients should continue on drugs. Have we seen any results from those studies?
Yes. So in the past, there was a time when they said a few things. Some people in some of these high towers have said, well, when older patients are not responding to these drugs, they don't work for them maybe. And maybe because it's a different kind of MS, and some of the older patients, maybe there's more of the degenerative variation. And then some people also said maybe as people age, the MS, quote, burns out. It's not as active. You don't need the drugs anymore. So they did a bunch of studies, and they said maybe in older people, we can stop these drugs. Which older people? People that are, the studies mostly have looked at people over the age of 55. Some have been younger. And they said these are people that are stable. To qualify for the study, they had to be stable. So you have no new symptoms. You're stable. You get an examination, it's stable. You have an MRI scan, it's stable. So everything is pointing to this person being very stable in every way that we can measure them. They said maybe you can stop their drugs. They did a trial. They did a few trials. And what they did is they put the patients, you put your name in a hat, randomized, we call it randomized, randomly, either you stay on the drug and you go off the drug, and then we're going to follow you for 3 years and see what happens. And we'll see if there's any difference. And what some of the studies showed really was kind of inconclusive in the sense that people that stayed on the drug or people that came off the drug, the outcomes weren't very different. It's not like people that came off the drug were all very stable. Some of them did progress. There was some progression and some worsening seen. So now some of the studies, like the study in Colorado, they're continuing it. There's a study reported from Amsterdam. There are other studies, a study from New York looking at patients. And all of them have shown that in some patients there is some progression. So I think right now we're kind of on hold on that. And what we do have seen too is that it also depends on what the type of MS is and the drug. For example, people that are on certain drugs like Tysabri and Gilenya, if they come off those drugs, there's a high risk for rebound. Those are drugs that have rebound. All the drugs in that family, Mayzent, all the drugs in that family have a risk for rebound. So we have to be very careful in planning what we do in those patients. Whereas people that have been on the older drugs, like Copaxone or Avonex for many years, generally can come off the drugs more easily. So right now, we're not, as a definitive thing, saying to do it. We're saying we still have to get some more information about it.
Thank you.
I have a question. To your knowledge, is the T-Rex gene correlated with MS?
The T-Rex gene? T-Rex gene. So patients with MS are related to dinosaurs? No, I'm not familiar with that. So the first thing about MS is that people that have one autoimmune disease generally tend to have other autoimmune diseases. So if you take somebody with MS and you look at their family, they're going to be people with MS. They're going to be people with lupus and Graves' disease and rheumatoid arthritis, a higher incidence of all of those. So yes, if you have one disease, if you have somebody with MS, it's not uncommon that they're going to say somebody in their family has lupus or another autoimmune disease. But we don't know why, because the genes with MS are not specific, they're widespread. But yes, if you have one, you're more vulnerable to get another one.
Great. Thank you. We're going to call it a wrap. Thank you very much for coming up here and to speak. I want to thank Sandoz and TG Therapeutics for supporting and sponsoring this program so that way we can make this happen. The Compass MS Care Series is who they are the sponsors of right now, so we do want to thank them. And I want to thank all of you from getting here, all those that are online. We can't possibly do these programs unless we have an attendance. So it's great to have you, and I want to thank everybody that volunteered to help this program happen. Thank you. Good night.